Thanks for coming, everybody. So before we start, I'm going to introduce you to all of our panelists that have joined us tonight. So right to my left, your right, is Susan Savage, a native Tulsan elected as Tulsa's first woman mayor in 1992. You can clap if you want. Her unprecedented tenure of service as mayor ended in 2002, after which she was appointed Oklahoma's Secretary of State by Governor Brad Henry. She served in that role from 2003 to January 2011. Susan's been recognized locally and nationally for decades of public service, organizational management, and her leadership. She currently serves as the CEO for Morton Comprehensive Health Services, which you probably passed on your way in here.
And we welcome you as patients.
It's the largest health center system in northeastern Oklahoma. Next, we have Carly Putnam with Oklahoma Policy Institute. She joined them in January 2014 and previously worked as an intern there. A Kansas City native, don't boo.
Yay!
Carly graduated from the University of Tulsa. Yeah, okay, clap for that too. She's a graduate of the Oklahoma Center for Nonprofits Nonprofit Management Certification Program, the Oklahoma Developmental Disabilities Council Partners in Policymaking, and The Mind, a social entrepreneurship fellowship here in Tulsa. At Oklahoma Policy Institute, Carly supervises policy staff and conducts research on healthcare and the safety net. And also joining us, we have Dr. Marianne Martin, the Senior Director of Communications at the Oklahoma Healthcare Authority, overseeing the agency's government relations, creative services, digital engagement, and data governance and analytics units. She received her bachelor's and master's degrees from the University of Oklahoma and her doctorate in mass communication from the University of Iowa. She's worked in the public sector for most of her professional career and lives in Norman with her husband and 3 daughters. So thank you to all our panelists for being here. And each of you has a microphone in front of you, so we'll just jump right in. And I guess we'll start with you, Susan. Just sort of give me an overview of your organization's stake in Medicaid, essentially.
If you didn't pass Morton or didn't notice it, it's that beautiful building just immediately to the east that was part of the Vision 2025 Public Improvement Initiative that Tulsa passed in 2003. Morton Comprehensive Health Services really was established following the 1921 race massacre, and it evolved from the Maurice Willows Hospital into Moton Hospital into Morton Comprehensive Health Services into a federally qualified health center, which means not that we are a federal agency, but we are eligible to receive federal funding as part of the Community Health Center System Network. 40 to 50% of the 16,000 patients who come 3 to 4 times over the course of a year into Morton for primary care, 40 to 50% of them are uninsured. What that means is, and we're not a free clinic, and so what that means is they come in the door already feeling a little disenfranchised. We offer them a sliding scale. There's certain services they can get. Because the state of Oklahoma has failed to expand Medicaid, it means that we have to struggle to fill the gap between what we generate in patient revenue and what the cost of treating the uninsured happens to be. And on a per capita basis, it's about $150. So we raise that money locally, and we raise it through a number of different grant programs. So that's what we do, and that's the face of Medicaid and the uninsured and the underinsured population. These are working families. They are people who need access to health care. We have chronic illness in our community. We have a sick populace. So we work very hard to address that. I know we're going to get into that in a minute. But as a former mayor and a Secretary of State who handled all of Governor Brad Henry's federal policy work, I want to tell you that at the local level and at the state level, we fall all over ourselves getting access to federal funding. We got it for airports, we got it for transportation, we got it for education, we got it for agriculture, we got it for flood control, we got it for emergency disaster relief, we got it for summer nutrition programs, we even get some for healthcare. So the notion that this is somehow different eludes me. I don't get it. It is not different. It is solely a political discussion that we have been having and beating to death at the expense of people who can't afford health insurance, who fall into that gap. They don't qualify for Medicaid because of state budget cuts, and they don't qualify on the exchange. They are sick. They do get health care. Lucky Layman's can tell you, they come into Ascension Hospital, into the emergency room. We pay for it through cost shifting. I'll stop now.
Thank you, Susan. So she mentions the coverage gap, and Carly, I think Oklahoma policy's stake in Medicaid makes you pretty familiar with that, right?
Yeah. So also, why would you make someone go after Susan? Why would you do this to me?
I didn't pick the seating order. That's what I understand.
We'll talk later about who I need to go talk to. So, OK Policy operates under the theory that Oklahoma can be a great state. We can have healthy families. We can have schools where the textbooks don't say that Brad Henry is still governor. We can have roads where you don't blow out a tire trying to get to Quick Trip. But it takes certain investments to get us there, and we provide facts, analysis, and advocacy around those investments. When Oklahoma has the second highest uninsured rate in the U.S. and the fourth highest child uninsured rate in the U.S., we are not setting families up to succeed, we're not setting communities up to succeed, and we're not setting the state up to succeed. Right now in Oklahoma, the line I use, I'm a childless single adult. If OK Policy went away tomorrow, I would not qualify for Medicaid. And there are 110,000 people like me, people who are adults who don't earn enough to qualify for subsidies on healthcare.gov, but either have children and make more than $8,000 a year, which I believe is the cutoff for a single parent with one child. That's lots and lots of people who are getting by on a hope and a prayer, and hoping that cough doesn't turn into something worse, and hoping they don't step wrong off a curb, and hoping that just by eating right, they're going to keep their insulin under control. We can do better, and we have to do better. And if we want our state to succeed, and if we want our state to be the top 10 state that we know we can be, we've got to make different choices, and that starts with giving people access to the health care that they need.
And then Marianne, the Healthcare Authority, essentially administers Medicaid in Oklahoma, right?
That's correct. Oklahoma Healthcare Authority is the single state agency that runs or administers Oklahoma Medicaid, which is known as Sooner Care. We also administer Insure Oklahoma. So, we politically don't have a dog in this fight, but if expansion were to happen, we would be responsible for administering it. So, right now, since it's kind of been ignited again, the agency is we don't want to, say something does pass and June 1st, we have to move forth with trying to expand Medicaid. The agency, I will say, is trying to plan for it because it will be a monumental undertaking by the agency. But having said that, if not, then we go on as business as usual. But if they do pass it somehow, either through the legislature or a ballot initiative, the agency will be the one to carry it out.
All right. So I think as at least a couple of you mentioned, Oklahoma is one of the states that has not expanded Medicaid under the Affordable Care Act, and I think that puts us in a company of around a dozen states at this point that have not done so. That's not to say that lawmakers aren't considering things that are sort of in the realm of Medicaid expansion. One of those that is now dead, but it was being talked about, was Senate Bill 605, which essentially would have tried to secure federal Medicaid funds and put them toward Insure Oklahoma, which is a subsidy for insurance premiums on the private market, correct?
Well, actually.
This is why we have the experts here.
Well, and I had to study up on this myself today. Thankfully, the other experts are here in the room. But so it would actually be something called the Oklahoma Plan, and it may or may not have a premium component. But currently, Insure Oklahoma it's supported not by TSET dollars, but by a separate tobacco tax that was determined by statute before TSET was created. And there's a portion that the member pays. So there's like the premium, right? We all know what premiums are. So the member pays no more than 15%. The small business owner pays no more than 25%, and then the agency covers the rest. And so that's 60% of the remainder of the premium. 66% of that, which is our FMAP, I can go into that later, but that's the federal match that we draw down from the federal government. That comes from the federal government, so the remainder of that is actually what the state picks up. So as you can see, I think we did quick math earlier, and it's roughly $57 per individual. That's on Insure Oklahoma. That's what the state has to contribute to cover their insurance. So with the Oklahoma Plan, there would be something different. So, I mean, it'd be that same sort of idea. The premium, whether or not there would be one right now, we're estimating, well, it would be up to 100% of federal poverty level. It would be a $5 premium that the member would have to pay. And then these are what the estimates that we've put forth so far. And then up to 138%, it would be $10 a month premium. So does that make sense? So, and I just want to, a point that I'd like to make is that what is key to Medicaid expansion is the populations to whom it is extended to. So, again, in the state of Oklahoma, we cover parent caretakers up to 40% of the federal, 45% of the federal poverty level. So you have to have a child, or you have to be a caretaker for a child, and that has to be your yearly income. That's 45% of 100% of the federal poverty level. Right? So I just want to make that clear. If you're a child, depending on your family arrangement, your family can make up to 185% under CHIP to qualify for sooner care. And then you can be age-blind and disabled, and these are federal categories. These are not words that we would technically choose. So age-blind and disabled up to 100% of the federal poverty level. And then there's a few other really, really, really small categories, like breast cancer and cervical cancer coverage, some pregnant women, and then a few other tiny little, more nuggets, little pockets of Oklahomans qualify, but we do not cover currently what are called able-bodied adults. So yes, Carly would not qualify for sooner care under any circumstances in the state of Oklahoma. So to expand, you have to cover Carly if she lost her job, for instance, or was unemployed, or was uninsured and employed, right? So does that, so you're saying, so I think there's a common conception in the state that we have people that don't have kids, that don't have a disability, that have access to sooner care, and they just don't. So the key to expansion as well is you have to cover this able-bodied population up to 138% of the federal poverty level. And for that group of people, you receive a 90-10 match from the federal government. So 90% of the cost is covered, 10% the state has to pick up more. So, I mean, those are kind of, I think for me, 6 years ago, I had no clue, so what's expansion? What does that mean? When they say expansion populations, that's who they're talking about. It's the able-bodied population that, does not have to be covered under the Social Security Act. So. Yeah, we're just going to take the conversation from you. So you didn't know what you're signing up for.
I'm going to give a very small soapbox for a moment. Though when we talk about able-bodied, what we typically mean is people without disabilities, but it's people without really, really significant disabilities. So people who have MS but have been unable to get, a disability determination, depending on how things are described, you may not be able to get sooner care in Oklahoma. And so we know that a lot in states that have expanded coverage, we've actually seen the rates of disability determinations decrease because people who have disabilities are able to get health coverage without needing to sign up for SSI or SSDI, which is a pretty grueling process. So when we're talking about able-bodied adults, we're still needing adults with depression, we still need adults with autism, we still need adults who may have some mobility impairments that are just not significant enough to meet a very, very high threshold. Sorry.
The 90-10 match is, by the way, what we do through the Surface Transportation Act for airports. It's pretty standard, that kind of ratio. I want to put a little bit of a face on some of the numbers and the statistics that you're hearing, because while Medicaid will cover children and, as Marion said, pregnant women, there are things that Medicaid won't cover for pregnant women who are on Medicaid, oral health being one of them. You talk to any health practitioner, and I say this because during the budget cuts of the last 8 years, there were benefits, Medicaid benefits that had to be cut in order to balance the budget. So that was not an agency issue. They were just handed, here's what your budget is. And they had to figure out how to make those numbers work. So we have raised at Morton hundreds of thousands of dollars over the last 5 years to treat pregnant women who come in for prenatal care who maybe have an infection in their mouth, because if you're pregnant with an infection in your mouth and it goes untreated, you are much more likely to miscarry, to have some kind of problem with that pregnancy. So these are all intertwined and interconnected, and we tend to look, I think, at this Medicaid discussion as, well, what does a person get in the way of benefits? It's an insurance program. It provides coverage for certain kinds of primary care services that are eligible. It's not a direct benefit that a person gets, it's access to care. And I think sometimes the conversation gets convoluted around with Medicaid and Medicaid expansion. It has taken on a life of its own. We're really talking about an investment in people. It's an economic issue, it's a workforce issue, it's a livability issue, and I don't know how we can expect a sick populace to get them to go to work. We have those issues in our community.
Hey, can you tell me how many kids in Oklahoma are born on Sooner Care?
No, I can. It's a lot.
A percentage.
I think it's around 50%.
I think it's a lot more than that.
Well, our numbers say it's about 50%. So
I had heard on public radio those numbers higher than that. But my point is that I've got some clinics, and we see over 15,000 Medicaid patients a year. And one of the biggest problems that we have is mental health. And when you say we don't cover adults that are able-bodied, I disagree with that, because I see them every day. Now, what they're putting on their paperwork, I mean, I don't see that. I don't know. It's not my business. But I know that there's people that come to our clinic every single day that are able to work. See, our problem is our society.
Why don't we take that up in just a minute, because I know Matt wants to ask some additional questions and then take questions from the audience. But I'm very interested in that, because Medicaid is Morton's largest payer, and we can have some exchange about that.
Yeah, we'll have a time for audience questions coming up in a bit. So going back to this potential plan that we had to get more people subsidized essentially by private insurance. Whoever wants to jump in on that, what would have been the potential benefits of that, considering the space that we're in?
I'll talk a little bit about that. So the benefits would be, there would be over 200,000 Oklahomans who would have access to insurance. And so in theory, they could seek preventive medicine and It's a lot.
A percentage.
I think it's around 50%.
I think it's a lot more than that.
Well, our numbers say it's about 50%. So
I have heard on public radio though numbers higher than that. But my point is that I've got some clinics and we see over 15,000 Medicaid patients a year. And one of the biggest problems that we have is mental health. And when you say we don't cover adults that are able-bodied, I disagree with that because I see them every day. Now, what they're putting on their paperwork, I mean, I don't see that. I don't know. It's not my business. But I know that there's people that come to our clinic every single day that are able to work. See, our problem is our society.
Why don't we take that up in just a minute, because I know Matt wants to ask some additional questions and then take questions from the audience. But I'm very interested in that because Medicaid is Morton's largest payer, and we can have some exchange about that.
Yeah, we'll have a time for audience questions coming up in a bit. So going back to this potential plan that we had to get more people subsidized essentially by private insurance. Whoever wants to jump in on that, what would have been the potential benefits of that, considering the space that we're in?
I'll talk a little bit about that. So the benefits would be, there would be over 200,000 Oklahomans who would have access to insurance. And so in theory, they could seek preventive medicine instead of emergency medicine, right? So, and you know, I've been pretty open about this when we've met with legislators, and the difference between talking about Medicaid expansion in 2019 versus in 2011, 2012, 2013 is there's now a boatload of research on expansion. Like there's a whole body of literature on expansion, what it looks like, what it means, you know, how it smells, you know, I mean, there's a whole bunch of information out there. And so when we were first approached as an agency to kind of give some numbers and estimates of how many people would be covered, what the cost would be, I kind of went into this rabbit hole and went through a bunch of the research. And what we know is that in states that have expanded Medicaid, the populations that were covered tended to be older white men. You know, so a lot of stereotypes are kind of turned on their head when you look at the states that have expanded Medicaid. So they're older white men who are on the verge of some chronic illness. And because they suddenly have insurance, they have a source of economic stabilization, and they are better able to maintain work and keep up their work, and they are able to manage their health. And so you know, I will say that the Healthcare Authority and Oklahoma Medicaid, Sooner Care, we already do our square best, our level best to help Oklahomans, you know, covered by Sooner Care, manage their health care. You know, we do everything we can to make sure that those with complex medical needs, health needs, receive wraparound services so they can access the care that they need. However, if those new Oklahomans were covered by Medicaid, you know, the research shows that they would probably access care earlier, that they would be able to manage their chronic conditions and maybe, you know, get rid of them, right? So if you're pre-diabetic, maybe that is taken care of. And the providers that we talk to, I think you would talk to the Hospital Association, for instance, and they would tell you our hospitals would be in much better shape because uncompensated care would suddenly be not uncompensated. So there's a lot of things that we know based on research about what would happen. But again, you know, it hasn't been, we don't know what it would look like in Oklahoma. A little bit of like wonkiness for you. There's like different ways to expand, and I know that folks that are kind of in the legislature that are really spearheading this. They have different ideas about what they want it to look like, and I do want to reassure that everyone that our conversations show that they are mindful of the behavioral health crisis that we have in the state, the lack of access to behavioral health services. They are mindful of the substance use disorder crisis that we have in the state of Oklahoma, and a lot of the questions that they're asking us about expansion are around those two issues specifically. Because we know and they know that more needs to be done to address those issues in the state. So, so there's different ways that you can apply that expansion could happen, and that be largely probably through a waiver. And so that gives the state a little bit of flexibility in how they would deliver expansion, but the key piece to all of it is it has to go to that population. So, so again, there's some policy, like, foundation laying for all of it. But we would have to tell the federal government this is how the state wants to execute expansion in order to draw down that 90-10 match, because that's the carrot. That's the carrot, is that 90-10 match, which is higher than our current match, which is 66%. They gave us 66%. So the actual plan, the Oklahoma plan right now is similar to the Insure Oklahoma plan though. So, long answer.
Susan, do you have something?
Well, you do get caught up, or we all do, in the mechanics of it. And I was thinking as you were talking, there about a third of the House, I think, is new this year. And so there's been a lot of education. And Morton, along with Community Health Connection in Tulsa, we're part of a network of community health center systems. 20 of us statewide. We serve nearly 300,000 patients across the state, most of whom, even in rural areas, there may be more Medicare there, but most of the patients, the largest payer source is Medicaid. So we, and for some reason, the community health center systems in Tulsa, we have higher rates of uninsured here than we do in other parts of the state. And so I keep going back to what I think is a very short-sighted view on the part of our policymakers for the failure to expand Medicaid, because it really is an investment in people. We sit here at the food bank, Morton's across the street, in a zip code that the Lewin report showed now, I think 12 years ago, there was a 14-year life expectancy, less of a life expectancy, and I live 5 miles south of here, just as the crow flies. It's now shortened to 11 years, so we're feeling good about that. At least it's going in the right direction. But there is no reason why people who live in this zip code and others in certain areas of our city should have a life expectancy that is 11 years less than where I live, for heaven's sakes. There needs to be access. There needs to be reliable access. Most of the people we see, especially the adults, are chronically ill. Diabetes, heart disease, respiratory problems, all of it is interconnected. And to fill that gap for those uninsured people, Morton just received a $200,000 grant from the George Kaiser Family Foundation for diabetes treatment, not prevention. This is not pre-diabetes. These are diagnosed patients. Food Bank is a partner with us in that. They're providing fresh foods. We're doing diabetes education. The Hutcherson Branch Y is teaching exercise. Our behavioral health people are helping to counsel. We are trying to do all the wraparound with a $200,000 grant. We're providing all the staff. This goes solely to provide treatment, medicine, and training for these patients, because we think we can have a tremendous reduction in or improvement in the management of diabetes. Eye exams, oral exams. It is a tremendous problem, and if we keep ignoring it, it just gets worse. And we treat it on an episodic basis, and that means costs continue to rise. So I know sometimes in the legislative session, they have to drill down into how does this actually work. But it makes me want to jump up on the table and yell, get over it and let's just do it. We have people who need to have access to health care in our communities, not just Tulsa, statewide.
So Susan mentioned a lot of legislative turnover this year, and that made me sort of think back to last session when the focus was sort of on work requirements and how do we institute these different requirements for people to work however many hours a week to stay on Medicaid and that sort of thing. And it sort of, to me, seems like we've gone the opposite this year, and though we're not considering full expansion, we're tossing some ideas around to partially expand or something like that. Carly, I wonder if you get the same sense in that.
Oh, how long do I have to talk here? So
3 minutes.
Okay, it's gonna be a cattle prod.
A little longer.
15 minutes. So Senate Bill 605, I believe, did nod to a work requirement. So the idea of the work requirement is that if people do not fully document that they are working or volunteering enough hours, then their health coverage is terminated. And the theory is that this gets people into work. The problem is that ample research shows that most people on Medicaid who can work do work. It is not a lot of fun to live in poverty. The federal poverty level for a single adult is $12,490. And so we know most people who can work do work. And we know that most people who can't work, who aren't working, have pretty solid reasons for not working. They're taking care of a loved one, a child, a parent, a sibling with a disability. They're going to school. I think we want to encourage that. They have a chronic health condition that prevents them from working or makes holding a job difficult. Or they simply don't have access. There are not jobs where they are. So yes, last year, Oklahoma passed a bill for the Healthcare Authority to create a plan to ask the federal government for permission to be allowed to cut coverage for adults who don't meet a work requirement. Of the adults, remember who Marianne was talking about, are on Medicaid in Oklahoma currently. We've got parents cutting off at 45% of the federal poverty level. The state will be exempting parents of children under 6. So the federal government hasn't made a decision yet on ours. A court decision came down earlier today, which made me very happy, but will not have any material effect on our plan. So the state seems to be moving forward with something like that. My hope is that their enthusiasm is somewhat dimmed. There's some pretty solid research out of Arkansas. 18,000 people lost coverage in the first 6 months that the requirement was implemented. And some pretty solid research showed that most people thought they had done what they were supposed to do and got cut, never knew about it in the first place and got cut, or had, no, that's it really. So our hope is that the brakes will be put on there. I am excited to see that we're starting to take the conversation away from what can we take away from people and more how can we help people. Ohio has done a huge amount of research into expansion in their state. They found that of people who got coverage through Medicaid expansion who weren't working, 75% said that getting Medicaid helped them keep looking for work. Of those who were working, the first time they asked, 50% said that having Medicaid helped them keep working. When they came back a few years later and asked again, more than 80% said that having Medicaid helped them keep their job, which makes a lot of sense. So coming back to me as an example, I have asthma. My lungs don't work. If I misunderstand a website, miss a deadline, don't understand a piece of mail, don't log my work, and my coverage gets cut off, I do not become a more attractive employee if I don't have an inhaler. My boss can tell you I get substantially worse at my job when I'm in the middle of an asthma flare. So to my mind, work requirements are very much a step in the wrong direction. In Kentucky and Arkansas, plaintiffs have sued over their state's attempts to implement a work requirement. The judge ruled today saying that Arkansas basically needs to go back to the drawing board and Kentucky needs to stop implementation that they had planned, pointing out that the statutory purpose of Medicaid is to provide affordable health coverage to low-income populations. And the defendants had not, I'm not a healthcare lawyer, so Teresa, don't come at me, but the defendants had not managed to clearly show how implementing this requirement was in line with the statutory purpose of their Medicaid programs. My hope is that after a bunch of states jumped on this, that we're going to see the pendulum starting to go back the other direction once they understand how difficult this is to administer. I think research suggested that between 60 and 90% of people who are going to lose coverage under a work requirement were going to lose coverage because they got tangled up in red tape. I think the experience of Arkansas shows that is perhaps a low estimate.
When Carly says, I just want to give this one fact because it's sitting here in front of me, parents who have incomes above 48% of the poverty level, which is $7,400 for a single mother with a child, for example. So we're not talking about a lot of money here.
And bearing in mind that people who make over that and their employer does not provide insurance, they have nothing. Yep. They cannot get insurance. I have a lot more questions, but I'm sure all of you do too. So at this time, we're going to open it up and we'll take questions from all of you for our panelists.
Could I ask just one thing? When you refer to 145%, could you translate that into a dollar amount? Because I think to a lot of us that doesn't mean very much. We don't know what that is.
Yeah, so the 45% of the percentage of, I'll do break out the math really quick. I could be way off, but I think for a family of 4, 100% of federal poverty level is $24,000 a year. So 45% of that is what the parent caretaker can make.
Thank you.
Yeah, is like 25? Yeah, something like that. Yeah.
If you have a question, raise your hand so we can go around. Thanks. Shelley.
So how can we give our state elected officials political cover to make this happen? What's the best way to do that?
They need to hear from you. And there's so many different ways to make this argument, and there are so many different people in this room who have experiences every day that they can use to tell a story. From a law enforcement perspective, imagine if our jails and prisons were not filled with people having the worst mental health moment of their life. Imagine if people had been able to get treatment before they were in crisis. Imagine if they were in crisis and we were able to get them into treatment once they were out of crisis. From an education perspective, imagine if we had more kids whose parents were getting treatment for the illnesses that make it harder for them to parent. Legislators love talking about adverse childhood experiences. An adverse childhood experience, one of them is having a parent with an untreated mental illness. Another one is having a parent in poverty. We know that when states have expanded Medicaid, rates of bankruptcy filings go down. There are so many different ways that the effects of this would ripple outward that legislators would love to hear about. And if you go to coverok.org, you can send a letter to your legislator, you can sign your organization on to support, and you can join us at the Capitol on April 24th to let your legislators know this is something you care about. Thank you, Shelley.
And Shelley, I would add to that, I think because the discussions get very bogged down in the facts and the mechanics and the details, I think you've got to put a face on the problem. I think to the extent, and we invite legislators, I'm very pleased to say Congressman Hearn has visited Gordon, Senator Langford, members of our Tulsa delegation, not even beyond those who just represent this district. So a lot of contact, a lot of expression that this is not simply a benefit for a person, it strengthens the entire state, the workforce, that, and it keeps our children healthy and our families healthy. And I think as we consider what we hold dear to ourselves, it's really pretty basic.
Yes, if Oklahoma does get Medicaid expansion, will the hospitals that have already closed down be able to reopen again?
That's probably a big unknown, and Mary, you might have an opinion about that. Health facilities close not just because of Medicaid. That can be an impetus to push things along. But I think what you would see maybe on the other side of that, especially in the rural areas, would be the strengthening of those health facilities that do exist. I really believe that Medicaid expansion, and from that you then might see some additional openings. But Medicaid expansion is so important for hospitals. I mean, I know we have hospital folks here who will nod at that, because the people who don't come to us to pay a sliding scale, they go to the hospital emergency room for their primary care. Community health centers, statistics will tell you that going to a hospital emergency room is 7 times more expensive to go for a primary care visit, which is not primary care, than coming to a primary care center, a community health center. So it's all connected. I mean, we've got to strengthen our infrastructure, and that's what we're doing.
Excuse me, could you address how prescription costs factors in on Medicaid? I know Medicare doesn't pay for anything prescription costs, and the reason why I'm asking this is because I'm a diabetic. I take 3 medications every day, and I just got one of my prescriptions today, and because I have insurance, I saved $515 for a 1-month supply, and it was still almost $60. If you're low income, you can't begin to afford that.
You just made my point for the reason we have this diabetes program, because we offer, and it's for uninsured patients. Morton also has a 340B, what's called a 340B discount pharmacy program for all of our patients who qualify for it. So there are some mechanisms out there, but you are exactly right. If you don't have insurance, your access can be restricted quite a lot.
I don't know how Medicaid really factors into the cost of drugs, but I do know, that it is one of the top 4, I believe, of our overall costs to the agency. It's not a cost that we can control, but we do have to cover drugs. So, and I think our agency and our pharmacy departments in particular is very proactive in identifying what are the most effective drugs. So there are mandates as to what we have to offer. We have a formulary like most insurance companies, but I mean, it very much is a budget line, for the agency. So, we understand, we feel you, but it's not necessarily Medicaid programs that, or Medicare that drives those costs. So, yeah.
And it's my understanding as well, and stop me if I'm wrong, that there's limited cost sharing for people on Medicaid. So people on particular drugs.
That sounds right.
Cool.
Yeah.
So the idea is if we expanded coverage, people would still be protected from some of these extraordinarily high costs.
All right, I have our next question up here.
Our previous governor didn't accept Medicaid. I think this one is too. I'm not trying to be political, but why aren't we accepting federal dollars? What's the deal?
My understanding, I'll just say, is that they do have concerns about that 92 match going away somehow. They do have concerns on the stability of the federal dollars, and so. The conversations that we've had with legislators, they do have some wariness as to the constancy of the federal government. Whether or not we can assure them, as to the validity of those concerns, it's really, we can't do that. But my understanding is that they do really worry that, 2 years from now, there's going to be a drop in that 92 match for the expansion population, and they already see what our budget is right now. But I'm going to make another point. I do want to reiterate, though, that we have a lot of people, new faces in the legislature. I think overwhelmingly, though, they know that we have some very pressing health concerns in the state of Oklahoma. That again, behavioral health is an unmet need for so many people. Substance use disorders are an unmet need, something that we need to address. And I can tell you that regardless of what your partisan affiliation is, that all 150 of those members at the Capitol really are looking for solutions. So we'll see where it goes this year.
I'm not quite as diplomatic as Mary Ann will say. I think this has been nothing other than a political discussion. It has been a strident political discussion based upon President Obama. He passed the Affordable Care Act, and there has been litigation. I mean, if you look at the history of the Affordable Care Act, because we've had several iterations of the Oklahoma plan in the last 9 years. The 90-10 argument to me is really academic.
They do have concerns on the stability of the federal dollars. And so, the conversations that we've had with legislators, they do have some wariness as to the constancy of the federal government. Whether or not we can assure them, as to the validity of those concerns, it's really, we can't do that. But my understanding is that they do really worry that, 2 years from now, there's going to be a drop in that 92 match for the expansion population, and they already see what our budget is right now. But I'm going to make another point. I do want to reiterate, though, that we have a lot of new faces in the legislature. I think overwhelmingly, though, they know that we have some very pressing health concerns in the state of Oklahoma. That again, behavioral health is an unmet need for so many people. Substance use disorders are an unmet need, something that we need to address. And I can tell you that regardless of what your partisan affiliation is, that all 150 of those members at the Capitol really are looking for solutions. So we'll see where it goes this year.
I'm not quite as diplomatic as Mary Ann will say. I think this has been nothing other than a political discussion. It has been a strident political discussion based upon President Obama. He passed the Affordable Care Act, and there has been litigation. I mean, if you look at the history of the Affordable Care Act, because we've had several iterations of the Oklahoma plan in the last 9 years. The 90-10 argument to me is really academic, because that's how transportation funding comes. That's how funding for airports. I mean, I can go through the list that I went through earlier. Federal funding always requires some form of match. And so what if it only lasts 3 years? That's 3 years of people who have access to health care. It gives us a chance
I've heard the 90-10 argument for a while now. You can build in a circuit breaker into the program, saying that if the feds ever drop their match below the agreed upon amount, we freeze the program. Mm-hmm. Other states have done it. We are not the first state to be paranoid about this. The other part is that the Medicaid funding formula has existed since the program was created. I wrote about this a couple of years ago. I believe The Sound of Music was in theaters that year. The feds have never backed off on their federal match. There is no precedent for the feds dropping the state's federal match. During even the ACA repeal fights a couple of years ago, what never came up was changing the federal match. There's not a history of Congress expanding coverage to people and then taking it back. we've said for a long time, we're concerned about the history, we're concerned about the future of the Affordable Care Act. We've said that for years. We've said that for the act was signed in 2010, right? So it's, yeah, 2019. The Affordable Care Act is functionally a fourth year. And while we've been hemming and hawing, millions of people in other states are getting access to the care they need. They're getting treatment for chronic conditions. They can fill their prescriptions. And we have 100,000 people who can't see a doctor. To come back to Susan's point, we need to stop hemming and hawing. It's time to do this.
So we've mentioned 90-10 several times, and I just wondered if anybody could put a dollar amount on Oklahoma's 10 at this point, just for context. Oh, good.
It's our projected we call it projected uptake, so how many people we think would enroll would be roughly, our estimate is about 250,000 people. That would equate, I could be off by a few $1 million, 1.1 billion federal dollars to 140 something million state dollars. So the state would have to cover that 140 something million dollars. Part of that would come through the premium payments, conceivably, if that's the route that they go. But those are the estimates that we have provided.
Can I touch on for a minute?
Please.
Does that include savings from Mental Health and Substance Abuse, Department of Corrections, and Department of Health?
No.
Okay. So in 2013, Governor Fallin commissioned a healthcare consulting firm to make a plan for how Oklahoma would expand coverage if Oklahoma were to expand coverage. It kind of got dropped almost immediately, and the finances have changed a little bit. A lot has changed since 2013. But then Levitt Partners estimated that the state would save between $400 and $600 million over 10 years. People who are currently getting care through the Department of Mental Health and Substance Abuse Services just for mental illness that the state is covering the full cost of, that we would instead be covering all of their health care needs and paying 10% of, which sounds pretty great to me.
And I mean, really, if anyone wants to nerd out some night, again, like I did back in December, I was like, I'm a doctoral student again. The Kaiser Family Foundation does have a literature review on, it's like 400 and something citations. Most of them are hyperlinked to the original source. So if you want to read up on it and then, go down that rabbit hole of chasing other leads within those sources, which is a good graspable tactic. Anyways, so you can read up on it. And it gives you a good, landscape of the national scene on Medicaid expansion. It's really very informative. I think Carly referenced the Ohio evaluations that they did. Governor Kasich's states, he had 2 evaluations, and it was a very robust evaluation. I think these are things that people don't think about when you think about Medicaid, but there's a lot of evaluation and analysis and, audits for days. Like, I can't tell you audits for days for, a Medicaid program. And so all that information is out there. It's public for people available to see, but then there's a body of scholars that have, gone down. And so there's lots of information if you really want me to fall asleep at night. Just look up the link and you'll be out in like 30 minutes. So
I was reading that report today. It's a lot of fun. OK Policies.
We're nerds.
We are. OK Policies. Communications Associate is in the back of the room, and Jessica, if I tweet you the link to that report, can you tweet it out? Yes. Thank you. So if anyone wants to jump on Twitter, I'm gonna be the millennial, get on my phone and send Jessica that link if y'all want to check it out. It's seriously a lot of fun.
We have, I want to make a point. We've talked a lot here tonight about the difficulty that people in our community and in our state face because of the lack of Medicaid expansion. And I have to tell you, working with the Oklahoma Healthcare Authority has been such an incredible partnership. They really, when Marianne says they care about getting resources out to the communities, they really do. And they have had, she won't say this because she can't, but they have had some really difficult working circumstances and budget situations to address over the last 8 or 9 years, and have done so professionally, consistently, and by listening to what the users of the Medicaid system, those who are trying to provide services and providers, have to say. And so I just want to compliment the work that you all do, because it's very important to our state, and there's been a lot of stuff about managed Medicaid, and we get into all that, and I don't want to go there. But the healthcare authority is really one of the most superbly managed state agencies.
And I'm going to second that, even though I work there. I just will tell you, if you're interested to know more about what Sooner Care looks like in the state of Oklahoma, Matt mentioned the Data Governance and Analytics Unit. I oversee it. There is a link on our webpage at the very top called Research. You can click on that and go to Data, and we go to Research and Reports and find out all sorts of information. We have dashboards. You can go to the county level, and there's a full report of every county in the state of Oklahoma, all 77, and you can find out so much information about the impact of Sooner Care at the county level here in Oklahoma. We have provided one-pagers today. This is my afternoon walking office to office in the Capitol with district one-pagers for every single legislator in the state of Oklahoma, so they can see within their district the Sooner Care information for their district alone. And I can tell you that there's been some visceral reactions when they've seen those numbers. And so all of that is available online. We have information about our reimbursement model, our formulas. I mean, all of it is on our website, which I will tell you hopefully from here now will be reorganized and more user-friendly, FYI. So I don't want anyone to complain because I know it's a beast.
Thank you.
Yeah. We've been hiding from you in particular.
We've been sitting and talking about Medicaid expansion in Oklahoma when, I think it was yesterday or the day before, there's now a call to repeal, once again, the Affordable Care Act. And what intrigued me about that whole line of discussion was the fact, I think it was either Pew or Kaiser Family Foundation, who said pretty much 90% of Americans like parts of the Affordable Care Act and would not want to see it go away. So I'm just sort of curious about why we would, I don't know, have that conversation. But we're going to keep pushing here in our state to get Medicaid expansion because it's really important to people, to families, to the health and welfare of our neighbors.
And just to go back to your question, sir, to bring things full circle as I like to do, we, again, on our website, the research tab I mentioned, compiled the latest information on the number of deliveries, Sooner Care deliveries in the state of Oklahoma. The last information that we have is from the year 2017. And the 50,214 deliveries in the state of Oklahoma in 2017, 29,031 of them were Sooner Care. So you can do the math on that as well.
So what my point, and that's, I'm glad it's lower than that because I've heard it reported, but that's unacceptable for our society, don't you think?
Well, let me probe you a little bit. What is unacceptable? That they're on Sooner Care, that they have insurance?
That we have women that are having children and don't have a plan.
Well, how is having insurance not having a plan, sir? I'm just going to ask you. You know, they went out and if they have Sooner Care, they receive prenatal services. I mean, I'm going to kind of push you a little bit on that. So
I don't think it's good for our society for children to be born without a mother, father, and a good, healthy home to raise up in. And
I would say, as a mother and a grandmother, that my children and my grandchildren have had good, healthy, have had access to services. We have a huge amount of poverty. We're sitting in the community food bank, and as you walk through, you see, here is the face of poverty as the slogan, and you see young mothers, you see old people, you see families. We have poverty in our state. We have areas of our community where people are homeless, they have no access to food. We're in a food desert right now. So, to me, the inexcusable part of the situation that you're discussing is the fact that we know it exists, and we have access to resources to try to address the problem and build healthier families, and we don't do it.
Well, see, but I think you're taking it wrong. I just want us to be building building for a better future. Because I see it every single day. I see people struggling. I'm from Chelsea, not Tulsa. They're struggling there every single day.
And they're struggling here. They're struggling right where we sit. You are exactly right about that.
And some of these dollars that we're talking about, everybody knows the saying, don't give them a fish, teach them how to fish. Some of these dollars needs to be going to that.
You know, I would answer that by saying anyone who walks in the door of Morton to get access, to register as a patient for access, if they're eligible for Medicaid, if they're eligible for health insurance on the exchange, we help them accomplish that. But 40 to 50% of them aren't. They don't have the resources. So pulling themselves up by their bootstraps when they don't have boots isn't going to get it. And so just to say, well, I'm sorry, we can't help you here. So we figure out ways to get them health care, because our job is to provide health care. And if you can make someone healthy, then maybe they can go out and do a little fishing, when right now they can't. We even provide transportation, because one of the #1 barriers to people's access to health care is transportation. We operate a transportation system, and it's damn expensive. But we do it because it reduces a barrier to health care, and it enables people to get access to appointments when otherwise we don't have a great public transportation system here. Not everybody has a car. So we've got to look at this less as what somebody is doing wrong, as Carly said, and how do we lift everybody up? Because it's the old saying, teach them to fish, yes. But if you lift up the poorest among you, you lift us all.
So can I kind of turn your question on its head just a little bit? Okay. In the spirit of discussion. So, I have a PhD. I get to dust it off every now and then. And one of the areas I study, and I've talked about this a couple times today, is development communication. And this is this whole field of study in communication where you look at how do you get individuals, how do you get communities, people to adopt new technologies, novel ideas, new advances. It was started at Iowa State, actually, when they were trying to get farmers to adopt different types of seeds and different type of practices. And so it's a well-developed science, not science, I don't like to call myself a scientist, but anyway, so there are some things that we know based on this body of research, and it's how, what are the general tactics that you need to employ to get people to change, not necessarily behaviors, but to adopt new ideas. And in this case, in the state of Oklahoma, it's preventive medicine. That's my position, is how do we get people to adopt the attitude of I need to go to the doctor regularly rather than in the ER, right, Susan? So this is the whole model of the FQHCs, is how do we provide all the services that they need so they don't end up in the ER. And when they end up in the ER, we call them afterward and go, why did you end up in the ER? Why didn't you come to the doctor first? And so it's this, but it's a mind shift, it's a culture shift, right? So you have to go to the doctor for your primary care visits. So how do we get people to do that? Maybe that would shift some of our indicators up a little bit, right? We wouldn't be 48th, we wouldn't be 47th in so many things. And so my theory, sir, not to attack you personally, because I'm not, we're having a conversation, that the mindset needs to be that the way to get people to adopt new ideas is to have your opinion leaders in a community outwardly share that idea, that position. So you convince the opinion leaders this is a good idea, and then the opinion leaders basically proselytize about that idea, and they get everyone in the community to kind of turn. So that's how you turn minds. So what I'm talking about is we need the opinion leaders in our communities to talk about how they use preventive medicine. How I have a PCP. Do you have a PCP? hey, we have an FQHC around the corner. Why don't you go start taking your kids there for their well child checks every year? You have a 14-year-old. Have they gone to see their PCP in about 2 years? Well, why don't you make sure they go to, because we know they're probably behind on their vaccinations. And so when you see the pastors, when you see the elected officials, you see the legislatures, when you see them start talking about, you know, I saw my PCP today. Oh, sorry, I was late to this meeting. They're running a little behind, but I'm here. When you see that kind of become a part of the vernacular in a community, that's when you start seeing the people, you know, regular everyday people kind of change their minds a little bit. So what I'm really saying is frankly, sir, you know, what I would say is that that mother sought out insurance. She had to apply for that insurance. She was trying to give her child something stable, something that helped make them better. And so, you know, I'm kind of the key storyteller for the state Medicaid agency. And what I really like to say is that insurance is an economic stabilization for people. And so they have to seek out and apply for insurance. This is something they have to maintain. They have to maintain their eligibility. So, you know, I just kind of want to shift your perspective, just kind of share it a little bit differently. Like, maybe she didn't have a plan when she got pregnant, but she kind of did when she applied for insurance, right? So, maybe
I want to thank all of our panelists for being here tonight. Thank you for your questions. Thank the food bank for hosting us tonight. Thank Matt for moderating, and thank our panelists. You were awesome tonight and some great information. I encourage you to sign up for our e-newsletter. We're going to have a new e-newsletter tomorrow. There'll be giveaways in that. Also, a great way to keep up to date with events, station information. And again, thank the food bank for hosting us tonight, and thank you so much for coming out.